All righty. Well, hello, everybody, and welcome to the Virginia HPV Immunization Taskforce, VHIT for shorts, HPV peer-to-peer series. We're so excited to have you join us today. If you wouldn't mind muting yourself during this meeting, and we will have a Q&A for you to kind of speak out freely. So just our agenda for today, we'll go through introductions, talking about some future learning opportunities. We're going to do actually 2 knowledge checks, so it's a little different this time. And then we'll go into our didactic presentation and finish with a Q&A session. As I said, good morning once again, or good afternoon. I think it's noon now. Whew, time's flying. My name is Janae Oliver, and I am with the Virginia Department of Health. I am a co-lead for the Virginia HPV Immunization Taskforce. Our task force is led by representatives from the American Cancer Society. Today we have Annika Dean representing for them, and then Virginia Health Catalyst, led by Erica Fassetti. And for this event, we have partnered with several organizations, as you can see listed, and we're so excited to connect with you all today. The mission of VHIT is to assemble stakeholders and unite partners promoting and supporting HPV prevention with a focus on increasing adolescent vaccination rates through the state with an evidence-based approach. VHIT is made up of 40 plus organizations, and we are a priority subgroup of the Cancer Action Coalition of Virginia. We are made up of 3 different subcommittees. We have our Providers and Systems Committee, our School Health Committee, and our coming soon, our Oral Health Committee, which should be beginning in the fall of this year. Oops. So as I said, this is our peer-to-peer series, and we have been doing this since really December of 2020. Every month we do it on the first Wednesday of the month at noon. We have our next one in August, so please make sure to join us and contact us, and also let your colleagues know. So jumping right into it, we're just going to do a quick knowledge check. Please put your answers in the chat. These questions are related to what our speakers will be speaking about today. So true or false, the HPV vaccine reduces the likelihood of developing precancerous cervical lesions. So feel free to throw that in the chat. Can I see this? Okay. See a couple of trues. See if the answer pops up. Okay, so if you said true, you're correct. True or false, in Virginia, women are unlikely to receive cervical screening for cervical cancer at regular intervals. I'll give you all a second, throw it in the chat. Seeing a lot of trues here. Ooh, we have some false answers. So is that the right? I hope that's the right answer. I think I took that right. So, and then true or false, Black women are 3 times as likely to die from cervical cancer as compared to their white peers. So I see some trues there. Let's see. So we have true. So if you want to know the answer to that, definitely listen closely for Dr. Huffstetler's presentation. So moving forward to who our speakers are, going to introduce Dr. Bernard Fuemmeler. He is Associate Director of Cancer and Prevention Control at VCU. Dr. Fuemmeler studies the biological and behavioral and social determinants that contribute to the developmental risk for cancer. Much of his intervention-based research employs the use of digital technology facilitating health promotion interventions, such as HPV vaccination among pre-adolescents. And he is also the proud husband and father of 2. So thank you so much, Dr. Fuemmeler, for joining us. Next, we have Dr. Alison Huffstetler. She is Assistant Professor of Family Medicine and Population Health at VCU and Assistant Professor of Family Medicine at Georgetown University. Her research is primarily aimed at increasing healthcare access, enabling population health, and improving care delivery. She focuses on improving cervical cancer screening through primary HPV testing, and her practices and teaching. She practices and teaches residents at Fairfax Family Practice in Fairfax, Virginia. So thank you so much, Dr. Huffstetler, for joining us as well. And then last but not least, our third speaker today, jam-packed. We're so excited to have you all, Dr. Shillpa Naavaal. She is a health services researcher and assistant professor at the Department of Dental Public Health and Policy at VCU School of Dentistry. She is a board-certified diplomat of American Associated Public Health Dentistry. Her primary research interests include access and healthcare use among vulnerable populations, oral health disparities, and dental medical integration. So we have a really awesome lineup for you today. Since we have 3 people, we're gonna keep it moving. So I'll pass it over to Dr. Huffstetler.
Thank you so much. Do you want me to drive the slides? Excellent. Can I get some head nods that you can see the slides? Beautiful. And I would invite anybody else who is off camera to join us on camera. We like to have the participation in the head nods and just a little feedback. So you're welcome to turn your cameras on. My name is Alison Huffstetler, and like they said, I'm a family doc and a health services researcher. And part of what I'm really interested in is helping people get preventive care that's necessary to prevent disease down the road. And so that's what I'm hoping to set the stage for today as we talk about HPV vaccinations and what they can do for the future. Now, being a researcher, I wanted to come in and give you this grand slam of HPV vaccines are the end all be all. They are going to totally fix cervical cancer specifically. So I went and I dug through the books and I wanted to look it up. And I wanted to say, here's this fascinating study that says 100% of cervical cancer is eliminated by actually giving the HPV vaccine. And here's the deal. I can't say that with 100% confidence. And that's because cervical cancer is kind of rare. And because it is somewhat rare, we can't draw that direct correlation from HPV vaccines to cervical cancer specifically. But what I can say is that there is a direct association between precancerous lesions and the HPV vaccine. And I bring this up because I think it's important that we recognize that all data and all research is a little bit limited. And so when we think about precancers, can you get a cancer without having a precancer? Probably not. And so it's very likely that HPV vaccines do directly affect cancers. However, I wanted to draw this distinction because it is fairly important. So how do we, as clinicians, look for cervical cancers associated with HPV? We look to the United States Preventive Services Task Force for recommendations on how to screen women and when to screen women for cervical cancer. The guidelines changed in 2018, and so I'm going to reference the most recent guidelines, but these have fluctuated in the past 10 years. And when I talk about individuals, I want to make sure that I'm talking about anyone that has a cervix. So I mean women, transgender men, and non-binary individuals. I might slip and say women, and I apologize, but my goal is to include all of those people in this screening bracket. Let's start from above 65 and work our way backwards. So individuals that are over 65 with a history of all normal screenings actually don't need to have any further cervical cancer screening because the likelihood of them developing cervical cancer is really darn low. And so we don't recommend screening any individuals over 65 years old. From 30 to 65, there are 3 different options for screening women. We can do cytology, which means just looking at the cells to see if there's any atypia, anything that looks out of the normal, every 3 years. We can do co-testing, which means looking at the cells and looking for HPV presence every 5 years. Or we can do HPV testing by itself every 5 years. And I'm going to come back to that idea because it's an underutilized one. For women and individuals 21 to 30 years old, we recommend looking at the cells only every 3 years. And why the difference? Well, HPV is ubiquitous. If there's over 100 strains of HPV, and so we think that many women and individuals with any that have ever been sexually active likely have been exposed to HPV. And so for those individuals, they almost would always pop up with a positive. We would overdiagnose this age range. And we know that HPV can be self-resolving, and so we choose not to screen those people for HPV because it would lead to an overdiagnosis. For individuals under 21 years old, we recommend not screening because, again, the development of cervical cancer in that cohort is pretty rare. So under 21, regardless of sexual activity or HPV vaccination, none of them should be screened. Now, what has happened over the course of time in regards to disparities for cervical cancer screening and for the diagnosis of cervical cancer? If you look at all screening, not just cervical cancer screening, but all screening, we know that Black women do not receive all of the women preventive services at the same rate as white peers, and the same thing for Black cohorts of individuals. Interestingly, Hispanic and Latina individuals do receive a lot of screenings. However, they don't have the same access to interventions after those screenings have occurred. So there are disparities along the entire spectrum of screening to diagnosis to treatment. When it comes to cervical cancer specifically, we see that Black women don't have the screening at irregular intervals in most places. However, they die at greater rates than their Caucasian peers. And so for every 5.2 Black individuals that die from cervical cancer, only 2.7 white individuals die. Now, those numbers change from year to year, but you can expect between 2 to 3 times ratio for Black individuals dying from cervical cancer, despite it being a very rare disease. Let me prove it to you. And I could do this through a couple different ways. I guess we could pull up some numbers and just look at that, but I think having a map brings this home with the group. So if you look at Virginia at large, this is a 1-year sample of where we are screening for cervical cancer. This isn't of all eligible women, it's just how often do we screen in 1 year. And we actually in Virginia do a really good job of keeping up with screening for cervical cancer. You can see the highest areas of screening are down here in the South Boston area, in the Hampton Roads area. And as you go up towards Northern Neck, you get a little bit less screening. So as of Virginia in total, we're actually doing a pretty good job of screening all individuals for cervical cancer who are eligible. But let's compare that to where we have the highest concentration of Black women living. Again, Tidewater area has a high cohort of Black women around Richmond, up in the Northern Virginia area along the Route 1 corridor, and in South Boston again. Now, if we compare that to even the low rates of cervical cancer diagnoses in the state, we see that those completely overlap. Again, the South Boston area in the southern border, Tidewater, 7 cities, Richmond, and the Route 1 corridor in Northern Virginia. Now, this isn't to say that every single case of cervical cancer is in a Black woman in those areas. We can give you those numbers, but I would like to bring this up because it helps us target interventions that are going to be more effective to getting women screened for and addressing an earlier stage cervical cancer, or those precancerous lesions, or where to do outreach for the HPV vaccine. So what comes next? Well, I think earlier I brought up the case that you can do just HPV screening in individuals between 30 and 65 years old. So what does that entail? It's a cotton swab. It can be done in the office by a clinician doing a vaginal swab or cervical swab, or it can be done by women at home. And a lot of research has been done into whether individuals would be comfortable doing that themselves at home. And it's been found that women are pretty knowledgeable about it when studied. Most individuals believe that it's an effective way to screen for cancer. And most people would say that they would do this as opposed to going into the clinician's office to get an actual pap smear or HPV test. And so we're thinking about this self-sampling method as a way to reach out to the areas in the state that have the highest rates of cervical cancer to encourage them to get screened earlier on. Now, we're in the process of this, so I can't give you the results yet, but I would anticipate that by screening people more frequently and regularly, we'll be reducing those rates of HPV-related cancers in the area. If I were to get out my crystal ball and look into the next 30 or 50 years, I think we're going to see even this idea changing, though, because HPV vaccines will probably eliminate the need for screening in general. In 2008, Australia was the first country to initiate a nationwide HPV vaccine program. And right now, about 80% of the women in the country and probably 70% of the males have been vaccinated. They have a rate of about 7 in 100,000 cases of cervical cancer. When I gave you a ballpark estimate, to screen for a cancer, for it to be beneficial on the epidemiologic, big picture, whole country type of situation, you need to have at least 4 in 100,000 cancers. And so what we anticipate is that Australia will not meet that threshold by 2066. So what does that translate to? It means that a person born in 2044-ish won't ever be screened for cervical cancer in their entire life. Now that may not be perfect, hence the asterisk, But I think it will be the case that we're going to see these rates going down because of the HPV vaccine. And hopefully that sets up us moving forward to talk about ways to target and do better outreach for the vaccine. I think I'll turn it over to Bernard next. Is that right?
Yes, that's right. Let me share my screen. That was a great introduction to my presentation, and let's see if I get my slides up and running. Okay, so I will be talking about geographic variation in HPV vaccination. And I'll organize my talk around three objectives. One is really to talk about the different ways that surveillance typically happens for HPV vaccination. And then I'll talk about a paper that we recently published that's a systematic review of studies that looked at area level variation in HPV vaccination in adolescents and young adults. And another paper that we have coming out probably within the next month, where we're using geospatial analysis to identify area level disparities in HPV vaccination using data here from Virginia. So you all are familiar with the NIS teens data. The data is collected via telephone interviews with parents or guardians, and vaccination history is confirmed by providers via mailed survey. And really it's considered a reliable estimate, especially at the national level, and to some degree at the state level, and it's often used as an estimate at the state level. But the sample size per state is limited, and so that really limits the power to characterize smaller geographic areas using these data. Another way to look at surveillance might be to look at provider-reported data on vaccines administered to children, and many states have immunization registries. And this can be used to track the increase or decrease in immunizations at small area levels and possibly identify areas of lower or higher immunization, controlling for population size. Residential addresses are often available, so that means you're able to look at where people live, where they're getting vaccinated, and sometimes data on the provider type and location where the vaccine is administered is available. But oftentimes state immunization registries won't give that information out, and ours in Virginia does not allow that information to be released. So some of the cons are the denominator problem. So it's difficult to determine the population prevalence for small locations if you only have data on the number of vaccines, but you don't have the number of the teens eligible. So you really don't know like what's the denominator. And the data can be quite difficult to work with. Sometimes we're talking about millions of cases here where you have records of vaccines in the database. So the data can also be inaccurate. So providers without EHR, for example, are less likely to contribute their data, or it's going to be difficult to get their data into the immunization registry. That makes it difficult to understand what's happening in those specific areas. And then provider compliance can be low. And so, state registries are often working with providers to make sure that they're able to get their data submitted. Another method might be using electronic health records or claims data. So again, this can be quite useful at identifying really at a systems level how well and where vaccines are being administered. And it can be combined with other data to understand provider characteristics related to uptake. Some of the cons, again, the denominator problem remains an issue. And without special approval, the address of the child or the teen may not be released. And so where the vaccine was administered may not represent where education efforts might be targeted, especially if the patients travel to see a provider, for example. So here are data for up-to-date HPV vaccinations among females and males from the NIS teens data for 13 to 15-year-olds. You can see that the coverage estimate for girls is a 41%. And look at the confidence intervals, very wide. It's really a sample size of 129 girls and 118 boys. So a very small sample size to estimate the prevalence, and you get these really wide confidence intervals within state. So first paper I'll talk about here is a systematic review of articles that were published that were looking at area level factors in relationship to HPV vaccination. And so we sought to summarize some of these articles. We used a sophisticated method and algorithm to search for search publication databases on HPV vaccination and geography. And we included studies that provided information on HPV vaccination by geographic area level variables. We found 733 articles, and from those, we were able to include 25 articles that kind of met our criteria here. So not very many studies, but some of the key findings from across these studies is that really most studies focused on larger US geographic areas, and fewer looked at within state variation. I think there were only 3 published studies at the time that looked at state level variation. And then, the initiation rate was 41% and completion rate was 23% across these 25 studies. Studies were consistent in finding lower coverage in southern regions of the US. So, but this was not, studies were not consistent in reporting differences, like, for example, in the Northeast or the West. Many studies agreed that that looked at this, that poverty at the zip code level was associated with higher vaccination, but there were mixed results with respect to rural and urban studies that looked at rural-urban differences. There's some consistent results suggesting that across a couple of different studies that looked at this, that suggested that higher uptake among males in urban populations was present. So higher coverage in communities with majority Hispanic was presented in a couple of these studies as well. And then there were some mixed associations with respect to communities with majority Black populations. And then again, lower initiation with higher level uninsured and provider shortages across a couple of these studies. So really, there are very few studies that have been looking at area level variation. And one of the troubling issues with trying to synthesize these findings is that the ways in which the definitions are all over the place in terms of how people were defining vaccination uptake, initiation, completion, and there were no real standardized methods across many of these studies. So we are recommending that, as a field, we really need to start thinking about how we use spatial regression modeling approaches and obtain data on vaccination coverage at smaller geographic areas. So in this study, we were aiming to do just that, is to look at area level disparities in HPV vaccination coverage using geospatial analysis. And the aims of this paper really were to model the variation in vaccination rates among boys and girls within Virginia and identify areas with significantly depressed vaccination coverage, and then determine if there are neighborhood characteristics that are related to the variation that we see in these areas. So we used data obtained from the Virginia Immunization Registry in 2019, and then we had almost 1 million records. So these were records that where people came in with their birth immunization, and we created a sample of individuals that were born in 2001, 2002, and 2003, who would have been 9 through 15 in 2010 through 18. So in this way, we could see of the sample of all the people that were born with immunization records, what did they look like as adolescents? And we noted if there was HPV vaccinations that were received and when the series was completed. We used some very sophisticated hierarchical spatial regression models, Bayesian hierarchical spatial regression models, to identify these areas. And then we used some machine learning approaches to identify the variables related to the vaccination completion, because we had a whole host of variables that we wanted to include. So here what you see in this figure is the lighter shades showing lower vaccination completion, and the darker shades showing greater vaccination completion. So overall, girls had higher completion probabilities, but just by a little bit than boys. But for in terms of area, there was really no difference between boys and girls, but in general, they had higher completion rates. And this is a little different way of looking at those same figures. Here, the red zip codes here are showing areas of the lowest vaccination. So you can see here where we have statistically lower levels of vaccination uptake and completion in the southwestern, northwestern areas of Norfolk and Virginia Beach, and this large swath running south of Alexandria through Sussex, with few exceptions and few differences for boys and girls noticed between these different areas. So what is related to the probability of completing a vaccination? What area level variables? We included 15 socioeconomic area level variables, and we sort of used our machine learning approach to sort of distill the most significant area level variables. And what we found was that higher probability of completion was associated with greater population density, maybe more urban areas, higher percentage of Hispanic population, greater racial ethnic diversity, and greater percentage of residents with a college education. All of these point to sort of the more urban, rural area, urban and suburban areas that might have these area level characteristics. And lower probability of completion was associated with average number of vehicles owned per household. So that seems like an odd area level variable, but it really reflects, in some respects, the rural communities where there are more vehicles owned per household, often because of farming vehicles. So to summarize, different surveillance systems can result in different estimates. We know that from all of these different methods. Different methods for examining geographic differences can also result in mixed findings with respect to how estimates vary. And there are really few good examples of using immunization data to estimate variation within the population. Ours is the fourth study that has done so, and the second study that used a geospatial analysis. And when done correctly, this could be useful, I think, in identifying areas where research could highlight reasons for hesitancy and where education efforts might be targeted. And that's what we hope to do with Dr. Naavaal's work. Hope to point out and then in a precision sort of population health approach, target those areas. So I just want to acknowledge that this is a team effort. I'm standing up here, but there's a lot of people here that really went into this work, and some colleagues at North Carolina, and of course, Christy Gray at the Virginia Department of Health. So thank you very much. And I'll stop sharing, and then I guess we can go on to Dr. Naavaal.
Thank you, Dr. Fuemmeler. I'll go ahead and share my screen now. Okay. So I'm going to kind of take this further. So we started kind of big picture and looking about how the screenings and at the bigger level, and then kind of examining how the data looks like the national level and where we are at in geography. And now we'll kind of go deep, dig deeper and look into the HPV vaccine hesitancy in rural Virginia. So just kind of, we did talk about some of these things, but I would like to point out some major pieces. As we see in the US, approximately 35,000 cancer cases caused by HPV in US every year. Cervical cancers were the important ones and the primary ones as the HPV vaccination started. But now, as the data shows, we have seen that oropharyngeal cancers have surpassed cervical cancer rates. And so that has become a big picture, especially in males. We see oropharyngeal cancers are much larger in numbers, and then they have surpassed the cervical cancer rates. Within our catchment area and within Massey Cancer Center, during 2015 to 2019, we see that trend similarly in all the HPV-associated cancer cases which were diagnosed. We saw that 41% were oropharyngeal and 22% were cervical cancers. So a really high burden of disease, high burden of cost with the HPV. HPV vaccines, we touched on that. A cancer prevention vaccine, as you all know, vaccines are preventing disease and therefore they're given earlier in time. So the right dosage amount and the timing for HPV vaccine is recommended to be between 11 to 12 years of age, but then obviously it kind of goes to a spectrum, and now CDC recommends HPV vaccines can be started as early as 9 years of age and can go up to 45 years of age. Obviously, up to 26 years of age, it's kind of given in these dosage, and about 27 to 45, every person's case may vary, and discussion with their provider would allow to decide if the vaccination is going to be useful and recommended for them. HPV vaccines have been safe, and more than 120 million doses have been given. And as Dr. Huffstetler described, a lot of work has gone in, but we still see in the United States, HPV vaccine uptake is suboptimal, much lower. So here is the data from our Virginia state, and it's comparing it to other adolescent vaccines. So these vaccines, these on the left side are regular adolescent vaccines, Tdap, MMR, Hep B, and we see that their vaccination rates are about 90%, almost for almost all the years that we are here, having from 2015 to 2018. Whereas in the same time period, HPV vaccination has been lower. It's comparatively newer vaccine, and therefore that could be one reason, but also at the same time, we see that it has been kind of moving around, and then compared to males and females, the vaccination rate has been, it has not been similar exactly. And then also at the same time, Healthy People 2020 and 2030 both have vaccination goals for HPV vaccination to be about 80%, but we are not there yet. So then what Dr. Fuemmeler showed, those graphs and those data points, they kind of show up here. When we see this closer view, we see that these counties, these dark red counties, are the ones where there are these pockets and the HPV vaccination uptake is much lower. For example, here is this pocket here in the south side where Greensville County is, and it is one of the counties with lowest rate of vaccination, about 21% initiation, which means the first dose, and the completion rate of only 10%. And then obviously there are differences by male, female, and gender, so that kind of also comes into picture. So this brings us to the reasons why, right? And therefore, the vaccine hesitancy. We are very, this word is much more familiar to us now with knowing the time we are in. We see there's a lot of vaccine hesitancy, especially around HPV vaccines. What is it? And that's why kind of we see these differences in vaccine uptake and the rates compared to all adolescent vaccine, how HPV vaccination rates are different. So vaccine hesitancy is basically defined as a reluctance or refusal to vaccinate, despite the availability of it. We know HPV vaccines have been available for many, many years now, but still we see that there is this kind of reluctance or refusal to kind of take that vaccine, despite of the safety and other efficacy trials done on them. And it's a continuum. The vaccine acceptance is more of a continuum, which ranges from accepting everything to refusing everything. And so here in the middle of it is where kind of the people where vaccine hesitancy kind of falls, and they might accept, they might have some hesitation, they delay, or they may refuse, but they're not sure exactly all the pieces of it. So looking at this, knowing the data, what we decided to do is kind of work and understand in those pockets where there is high, we saw low vaccine uptake, high disease rates. So we saw all those graphs where we see differences in diseases, differences in vaccine uptake, and try to identify what is going on, what are the reasons, and how to better understand what do people think about these adolescent vaccines. So with this study, we decided to do a multi-level, a mixed method study, which would involve parents, provider, community stakeholders, and kind of understanding it from various angles about what about HPV vaccine is something that is leading to this low uptake. So our three aims for the study were to determine reasons for vaccine hesitancy among parents of adolescent children. Decided to do this by doing a survey and a focus group. So mixed method research in which we were collecting both quantitative and qualitative data. The second one aim for us was to understand HPV vaccination practices and the barriers among healthcare providers. Because if we hear from parents, we kind of can understand that perspective, but hearing from providers and stakeholders will provide us more richer perspective in terms of knowing the whole story. So that second aim also was a mixed method, conducting a survey and focus groups and interviews with providers and stakeholders. And then the third aim with this community-based research is to disseminate these findings. Whatever we find, we would like to bring it back to the community so that we can really understand and share it. We understand it, but then we share it with them so that they could kind of see and help in kind of formulating the next steps. So this study is going on currently. It's a one-year study. We started in about last October and kind of started with developing everything. We have these three arms in the study: parent survey, provider surveys, and or parent group, provider group, and stakeholder group. I'm going to share the stakeholder results with you. Parent survey and provider survey are still going on, and we are collecting more data in it. And so I'll share the part of that we have completed. So in the stakeholder data, we decided we were focusing on these three counties. As I mentioned, those three counties in the south side, they're Brunswick, Dinwiddie, and Greensville. And in these counties, we decided we would like to hear, it's a pilot study, and so we decided we'd like to hear from some stakeholders, community leaders, who could give us their perspective in these counties. So two stakeholders from each county participated. They did the survey, and we talked with them. We did an interview with them. And these stakeholders varied in their roles. We had people from educational background, from a religious background, from all sort of different things. Educational leader, community leader, all these people. So 6 of them participated. And what we found from that surveys is that we collected data on some vaccine hesitancy overall, HPV vaccine hesitancy, and then also HPV knowledge and HPV vaccine knowledge. So I'm sharing some of the preliminary results with you all. We found that everybody was knowledgeable about HPV and HPV vaccine. And overall, when we looked at the HPV vaccine vaccine hesitancy in general, all adolescent vaccines, when we talked about them, that hesitancy was low. So we used some scales to determine that, and we found that people were knowledgeable about HPV and HPV vaccine, and these regular hesitancy was low. But when we looked into deeper and tried to see what was the HPV knowledge, we found that there were some gaps. Some areas were clear, however, there were some gaps in the HPV knowledge. Specifically here, as we see, and this is, again, it's a pilot data, but the data is coming from the leaders who are in the community. So it kind of reflects some of the understanding and kind of in the community what's going on. So the participants thought that HPV was very rare when we know HPV is very common. So that was kind of some gap over there. Some people thought that men could not get HPV. That was another part of it. And then HPV can cause some types of cancer or HIV. That area was also, knowledge was low in that kind of area. So this kind of shows us the area where probably education could be useful to improve and understand. But in some areas, as you see with this blue bars high, some of the areas very, very clear. HPV is transmitted sexually transmitted disease. HPV does not show many signs. So some of the areas were clear. Then we looked into HPV vaccine knowledge gaps. So what we saw was HPV knowledge was comparatively better. HPV vaccine knowledge gaps were more. And so here, the biggest one kind of was, the curious one to me was, as I kind of, and that's why I wanted to mention the beginning one, that oropharyngeal cancers are now on the rise and higher in number compared to cervical cancer. But when we asked people about oropharyngeal cancers and HPV vaccine can promote protection, none of them thought it could. So it was, everybody thought that HPV vaccines cannot prevent oropharyngeal cancers, whereas we know that recent FDA recommendations have been out to say that it can be prevented since the same vaccine, same HPV strains causes those oropharyngeal cancers. So that was a big gap. The second one was HPV vaccine requires at least 2 doses. People were not very aware of it, and they thought that there was some confusion over there. The clear kind of other areas here were the incorrect. So these orange bars kind of shows incorrect. And so again, here, HPV vaccines are most effective if given to people who had never had sex. People thought that that was not true. And so many people kind of incorrectly identified that. And then HPV vaccine is approved and recommended for females and males, both between 9 to 45 years of age. So those recommendation questions also were not very clear. So all in all, folks were not very knowledgeable or had some confusions in terms of HPV vaccine knowledge. So that was kind of area. And this is, again, this is 3-county, rural Virginia, and place where vaccine uptake is very low. So it is very important to understand where are these gaps happening. Then we looked at the HPV vaccine hesitancy, and we saw that HPV vaccine hesitancy was higher compared to overall vaccine hesitancy. So similar questions about adolescent vaccines, but for them, hesitancy was low compared to that for the HPV vaccine. And then when we asked them a question about if you would support HPV vaccination, people were in a mix. 50% were yes and 50% were no. So we see like there's a lot of kind of things going on in terms of knowledge, in terms of hesitancy, in terms of HPV vaccine, other things too. Here is just some quotations that I picked out from our interviews to kind of show where people are at. And kind of, it's a mixed method research, and that's the beauty of it, that we are able to kind of talk to people and they can share their thoughts. So overall, I would not go and read, but I'll leave it here so that you guys can see what it looks like. But I think the main thing, what it seems like there is some gaps in education, in information, and then people kind of want to know more, but they don't have those areas. And then also the connection of HPV vaccine with sexual transmitted disease is very strong and very tight. And so people kind of are more thinking in that. And so probably the education on what and how it protects not only in this age group, but over your lifetime, those kind of information are more needed. So this is just kind of a gist of it, that variety of insights came out, but the common themes were sexual activity associated with HPV vaccine and therefore more hesitation probably. Hard for parents to think about younger kids, especially the vaccine recommendation is between 11 to 12 years old, and therefore that kind of disconnect. Lack of information. Some people thought that it is really not necessary, and then safety or risk of the vaccine was another area. These are additional kind of themes that, based on these 6 interviews, we think that there might be these areas where efforts could be directed, so that need of education. Many people said, like, if more is known, we probably are able to make better decision, demonstrating the risk and benefits. So obviously everything is not good, everything is not going to cover you 100%, but if you can demonstrate what is the risk versus what is the reward, that could be helpful. Honest and clear communication was a big theme that came out, and people thought that more communication and more information from different groups, healthcare providers, departments, health departments, religious leaders. It's rural communities are very tight-knit communities and have very strong roots, and therefore engaging people where trusted leaders are could be a great way to kind of connect the groups. And then there were some more things about like policies related to HPV vaccine and how they could be good or how they could be bad, parent choice, respecting that rather than kind of, so those were other themes related to why HPV vaccine uptake has been different in these areas. So that's, there was a lot to unpack, but we were able to kind of, this was the stakeholder data. We still have, again, the other groups going on. This work is funded by NCI, and here are my collaborators. I have a great team. It's a group work, and that's all from me today. Thank you so much.
Thank you so much, everybody. We what great information, and love to see the pieces of all of it coming together from different perspectives, and all the great work that's happening. Are there any questions that our participants and attendees have today?
Not really a question, and I can think of a couple reasons why, but what's the presumption behind the fact that vaccine uptake is higher in more impoverished areas? A little interesting to me.
Well, you're talking about my presentation?
Yes, Dr. Fuemmeler.
Okay. Well, in fact, we looked at, I think somewhere around 15 or so area level socioeconomic variables that might be statistically related to completion rates as tracked by the immunization registry data. And, what we found was that it had to do with the higher completion rates had to do with population density, higher percentage of Hispanic population, greater racial ethnic diversity, and greater percentage of residents living in college educated, greater percentage of residents with a college education. So it was these sort of more urban and suburban areas where you see these kinds of characteristics that were more related to the higher probability. The only thing that was related to a lower probability was the average number of vehicles owned per household. So we really didn't find like indicators, and we looked at things like, median household income, average poverty, these kinds of things, level of poverty. These weren't related to vaccination uptake as we see them in the immunization registry data. So those are so targeting low income areas or targeting even high income areas is not where we need to focus. Where we need to focus probably is figuring out where these, well, you saw on the map exactly which counties have the lowest, statistically lowest uptake. And so many of these areas sort of are in these sort of rural populations, but some of them aren't. So, but we can't rely on these area level variables to help us. But we can rely on those maps, I think, to help us understand where some of the where we can target some of these areas.
Thank you.
I'll just bring up that slide again. So those red zones.
Yeah, the maps certainly are telling and a big help. It was that one.
There was some studies that have, there was some studies that have looked at this in the review article that we found, poverty. But again, it's really hard to make sense of some of those studies because of the different methods they used, and so we don't know as much as we think we know, I think.
Thank you, Dr. Fuemmeler. There was a question in the chat box also from Diane, just asking about if the vaccine can cause autism. And we had to skip through some of our pre-knowledge check questions, but Dr. Naavaal, is saying that HPV vaccination does not cause autism. Don't know if there's anything additional you'd like to share on that topic, Dr. Naavaal.
Sure. So it does not cause autism. What we did was we used that question to do a knowledge check about vaccines among our stakeholder group. And so there was that gap where half of the group thought that it does cause autism and half of the group thought that it does not. So then again, an area for education, an area for making sure that people understand that vaccine safety is kind of it does not lead to other diseases and does not cause autism.
Yeah, there is a lot of misinformation around vaccines, if you haven't heard about that with the recent COVID vaccine. So, that's something we all have to sort of understand where is this misinformation coming from and how do we correct it? And, and how do we show that some of these things get started through channels, social media channels, and misinformation on social media channels, and faulty science. And actually, that's one myth that got started from faulty science.
With the COVID vaccine being available for 12 to 17-year-olds, this has brought about a good bit of conversation with my adolescents and parents about vaccine safety, because when I think about the HPV vaccine, as a clinician, I don't say, would you like to get the HPV vaccine? I say, you're due for the HPV vaccine, just like I say for every other vaccine, the MMR, everything. I say, you're due for this. With COVID, it's brought around a lot of conversations of, is this safe? And I've actually seen more parents agree to get the HPV vaccine for younger kids because we're talking more about vaccine safety. So despite having a terrible pandemic, it's given us a lot of educational opportunities.
And I think that the issues that we face are challenging right now because we have now the HPV vaccine has to be timed so that it will be timed to be given when they're at a sort of interval of space after they've gotten the COVID vaccine. So that's going to be a challenge in, giving out, having kids come into school, and that expectation is that they would get the HPV vaccine. Well, first they have to get the COVID vaccine, and then they have to wait to get the HPV vaccine. So there's some challenge here that we're going to face moving into this post-pandemic era with regard to HPV vaccination uptake.
Great information. Thank you. Thanks for addressing that. Are there any other questions? Yes, Britta said definitely a cool silver lining with vaccine education. And I was thinking the same thing, Dr. Naavaal, when you're talking about, the survey and study, that's a great opportunity for us to learn where are there holes in our education in the community and what do we need to do to address which issues or concerns. So great, valuable information for sure.
Yeah, no, definitely. And I think with the new policy kind of coming up for school vaccination among boys beginning July, I think the more information we can share with every community, it could allow to alleviate some of this anxiety about not knowing things. So definitely a lot of opportunities in terms of like timing. And again, like right now, vaccination dialogue is going on. So kind of making sure that good and correct information is shared so that people don't latch on to the misinformation and kind of keep, because again, these are trusted leaders. So the wrong information spreads more faster than the right one. And so kind of definitely using this, these pieces to make sure our communication is more stronger and more clear is something that are definitely areas that we can kind of strengthen.
I am gonna, please keep thinking of questions if you guys have them. I'm gonna add in the chat box a survey if you guys don't mind to please fill that out for us and just let us know how we are doing, how the sessions are going, and what we can do to maybe organize and push forward with maybe a potential new series. And just wanted to share with you our next, oh, that date is wrong. I apologize. The next session is August. Let me get you that date, just one second. The next date is August 4th, and I will put the registration link in the chat box also. We're excited to hear from Dr. Emma Mitchell from UVA, who will be talking about the HPV home testing research that's happening in Southwest Virginia. And so we, again, just I'm gonna grab this August registration link. So if you have not already registered for the upcoming session in August, we do encourage you to go ahead and get oh, thank you. Dr. Fuemmeler also added in there the HPV roundtable meeting. Thank you for that link.
Yeah, so you can skip my talk on that one because it'll be exactly the same. But there's some other great talks going on at that meeting too, if you want to tune in for the public sessions.
Perfect. And I'm getting some chat. Janae, we might need to look at the survey for the June date in the survey. So we will send that out. We usually send out a post-event email, and we'll make sure that we have the correct link for the survey for you all. And if you have questions moving forward, please don't hesitate to reach out to the VHIT email. It should have been part of the registration confirmation for today's session. And we do really just appreciate Dr. Fuemmeler, Dr. Naavaal, Dr. Huffstetler, your all's time and information, great presentations. We really appreciate it. And thanks everybody for your time this afternoon.
Yeah, thank you for the invitation. It was great. Thank you so much.
Thank you, everyone. Great day.
Bye.